My biggest disclosure other than this list is that I'm a brandaholic. In the land of acne and rosacea, I feel strongly about vehicle technology and the improvements that we've seen over the last couple of years in both efficacy and in tolerability, if we can get them, to his point. So lots of our patients suffer from rosacea, and I really mean suffer, right? But not everybody with rosacea is held back by their disease, and most of our patients clearly are. You know that we've been talking about rosacea subtypes for a very, very long time. We were talking about erythematotelangiectatic and papulopustular and phymatous and ocular. But what we really know is that virtually every patient who walks in the door is a combination. So here we see somebody with what we used to call ETR and PPR together at one time. So in the last 10 years, we've been shying away from the subtypes, now starting to talk about phenotypes. And the importance of me talking about this right now is that we want to make sure when we sit down before a patient, we don't think about those old subtypes. We think about, what is this person in front of me? What do they look like? Do they have a little bit of redness, a couple of papules, some telangiectasias, a little bit of phyma, eyes look a little rheumy? Maybe they have all 5 components to their disease. And what are their symptoms? Are they itching and burning, and do they have ocular symptoms? So that we're describing the patient phenotypically rather than trying to squeeze them into one of those subtypes. It's important also when thinking about therapy. I was just having a conversation before I stepped up here about a patient being treated for background erythema with one of the drugs for papules and pustules. If you notice here, the drugs for papules and pustules do not work for background erythema, and the background erythema drugs do not work for papules and pustules. So that patient with combination disease needs 2 at least medications, or a medication plus a procedure, in order to get better. So this is a big deal for the patient. They came in for something, you're selling them 2 topicals, maybe an oral, and maybe a procedure to fix what's on their face. So you need to ask them what bothers them. I'm sure you've had an experience where a person comes in, bright red face, concerned about a couple of pimples, and you say, okay, I can make your pimples better, but is there anything else you want to talk about? Anything else you want to talk about? You know, the fact that you look like a tomato, you really need to ask them, because some things bother them and some things don't. So when we're trying to treat papules and pustules, we have an embarrassing richness of topical medications, but in my opinion, these last 3 are really where it's at. The older medications don't work nearly as well and have a lot of problems with irritation. So ivermectin brought us almost 40% clear or near clear. Minocycline foam brought us a 60% reduction of inflammatory lesions, 40% of which was in the first 4 weeks. Look at the slope of that line between baseline and week 4. Real jackrabbit start these new drugs have. And that's a very important statement, right? Because when the drug works fast, you have a happy patient. A happy patient is a happy doc, and the happy staff of the doc, right? And happy Yelp reviews, too, in this day and age, unfortunately. So that jackrabbit start really means a lot. And thanks to the use of mineral oil in this formulation, virtually no cutaneous side effects at all, even in patients with rosacea who tend to have sensitive skin. Microencapsulated benzoyl peroxide, or Epsilay, is the newest kid on the block. You have crystals of benzoyl peroxide which are wrapped inside a silica shell. And then the lipids and the phospholipids from the skin migrate inside the shell, dissolve the benzoyl peroxide, and bring it back out to the surface of the skin slowly. You don't end up with one big bolus landing on the skin at one time to irritate, again, the very sensitive skin of our rosacea patients. Here we see an almost 70% reduction of inflammatory lesions at week 12, and look at a more than 40% reduction in only 2 weeks now, so even faster. So here we see 2 patients who went from being severe to mild and near clear in only 2 weeks' time. This woman, a dramatic improvement in those first 2 weeks, continuing to do better over time. Comparing baseline to week 12, a huge improvement, I think you'd agree, but she's now only mild, so she was deemed a treatment failure. So she wasn't even included in those numbers that we were looking at before. For tolerability, you might think benzoyl peroxide, wow, that's really going to irritate the skin of my rosacea patients. Well, thanks to that microencapsulation, that was not seen. We do tolerability studies to make sure that the drug isn't causing tolerability issues, but here it actually reduced tolerability issues because our patients came in, they have rosacea. They're red and they sting and they burn and they itch, and the cream actually made those symptoms better. What about treating vascular disease? Well, as you're well aware, there are very many different types of redness and rosacea, and we need to make sure that we're picking the right drug. So we have persistent facial erythema, which is the hallmark of rosacea, for which we can use the alpha agonists. Flushing, though, does not respond to the alpha agonists, at least not in any significant way, and we may have to break out beta blockers to help these patients. Perilesional erythema is a completely different animal from background erythema. It's redness that occurs around the lesions, and when you treat the lesions, they go away. That redness resolves. And then finally, we have telangiectasias, which are going to require energy-based therapies. So you may have a patient that needs all of these things in order to control even just the redness of their skin. So now moving on to what's new in the acne toolbox. The last 5 years has been a real boon for the acne toolbox. We found a new formulation of tretinoin and tazarotene made with polymeric emulsion technology, which greatly reduced the tolerability profile of these two drugs. We saw the first fourth-generation topical retinoid that binds exclusively to the gamma receptor, allowing it to be formulated in an exceedingly low dose of 0.005%. The new combination benzoyl peroxide tretinoin, which is microencapsulated, minocycline foam, clascoterone cream, it just goes on. And then we had a bunch of new pills as well. And very shortly, we're going to have our first triple combination topical medication. We also, as you're well aware, have two new 1726 nanometer lasers to help us destroy our sebocytes. So we're really quite rich at the present moment. So since we're talking about topicals today, we're only going to talk about these three drugs. Starting with the microencapsulation now of not only benzoyl peroxide, but also tretinoin. And some of you may be saying, well, you can't put those two drugs together. They don't compete. The benzoyl peroxide chews up the tretinoin and inactivates it. Well, that's true, except that these things have been microencapsulated separately inside the container. So you have your crystals of benzoyl peroxide wrapped in silica. You have your crystals of tretinoin wrapped in silica. So the two things are actually segregated from each other in the bottle, and they don't separate out and mix together and cause that problem. You might also be saying, okay, I get that, but two concentration-dependent irritants with tretinoin at the highest concentration that we use topically, isn't that going to burn the daylights out of my patients? Well, it was highly efficacious. Yes, there's a huge difference between study 1, study 2, don't know why, but let's average them anyway, somewhere in the vicinity of 30% of patients clear or near clear, at 12 weeks. And here's the tolerability data. So that second line that has a 1 next to it represents mild. So you can see at all time points for all parameters below mild. That little blip that occurs at 2 weeks with every single topical retinoid on the planet is there, and it declines shortly thereafter. Clascoterone cream is our first new mechanism of action in acne for many, many years, basically since isotretinoin. It's an androgen receptor inhibitor, and it also has anti-inflammatory properties. It's rapidly metabolized in the skin to cortexolone, so it loses its anti-androgenic activity before it reaches the bloodstream and is therefore safe for use in men. So what other drugs do we have to suppress sebum production? Well, we have isotretinoin and spironolactone and oral contraceptives, and of course they have a lot of potential side effects, and the last two are appropriate clearly for women only. So isotretinoin prior to this medication was the only anti-androgen that we had for use in men, and obviously not everyone is a candidate. This drug binds by competitively inhibiting DHT. So you see normally DHT binds to the androgen receptor in the sebocyte. They translocate into the nucleus, say hello to DNA, and end up producing an increase in sebum and inflammatory cytokines. And clascoterone instead binds to that receptor, sends DHT on its merry way, and does not allow the transcription of genes calling for an increase in sebum and pro-inflammatory cytokines. In the phase 3 trial, about a 20% clear or near clear at 12 weeks, and very well tolerated. Finally, our new topical that's going to be coming out shortly. Let me ground you here. The dark blue is the triple combination, and the gray is vehicle, and the other 3 bars represent all the individual duads. This was a beast of a study with 5 separate arms. So you can see right away at week 4, the triple combination is starting to say, I'm a little bit better than the others. By week 8, even more so, and a dramatic difference between the duads and the triple combination occurring at week 12, a true synergistic response of these 3 drugs together in one container. So basically our toolbox runneth over, and I ask you, what's in your toolbox today? Thank you.